Let me know when you
Okay.
want me to advance the slides.
Yep. So I have no relevant disclosures. So I wanted to present a case today of a child I saw who was 15 at the time, and he was diagnosed with what was presumably type 1 diabetes at 11 years old. What was interesting about him is that he did present with an elevated A1C greater than 14 and in very mild DKA. His BICAR was only 14 and he had ketones. And he was associated with weight loss was his only real symptom, and fatigue. But all of his antibodies were negative initially. The only antibody that ever has come back positive was an insulin autoantibody that was positive after insulin had been started more than a year prior. So I don't really think that that counts. And after having diabetes for more than 3 years, his insulin requirements were only 0.2 to 0.3 units per kg per day. And on that low of a regimen, he had not developed pre-ketosis or DKA. And even when he had, reportedly insulin omission for without basal on board for a couple days at a time, did not go into DKA. So he initially came to me for second opinion because he was having severe hypoglycemia, which seemed to be actually related to him giving himself extra insulins, which complicates this picture. But when we did admit him and did hospital management only of insulin, that was his requirement, was 0.2 to 0.3 units per kg per day of insulin, basal bolus, with euglycemia. His A1C on a low regimen, well, we don't really fully know because it's outpatient. He was giving himself extra insulin, but his A1C has ranged from 7 to 9 as an outpatient in the last 3 to 4 years. His BMI has remained low. He's never been obese. He's never had acanthosis. And you can advance the slide. He also has situs inversus and a selective IgA deficiency, putting him at risk for autoimmune conditions. But again, we haven't found a consistent antibody with type 1, and his insulin needs are pretty low. Interestingly, dad has diabetes, but dad says he manages with diet only, and the only A1C he was able to tell me about was a 7% hemoglobin A1C. Dad's brother, who lived in Ethiopia as a child, died at 14 years old of diabetes. We don't know much more about his type, but just that dad said his cause of death was likely diabetes, but dad wasn't close with him at the time. This patient did have MODY panel with 28 genes that was negative. And we also screened him for cortisol deficiency just because of the low insulin needs and hypoglycemia, which was negative, and he was negative for celiac as well. And I think that should be it from this slide.
Yep, and that's your last slide, actually. So
yeah,
happy to.
So that's, I don't know if that kind of sums up why I was concerned that this is sort of an atypical sort of diabetes, just the extremely low insulin needs outside of what a typical honeymoon period would be. We tried to get C-peptide and insulin on him. And unfortunately, inpatient, not all of those studies worked out perfectly, but yeah, just a little bit of a confusing picture of why his insulin needs are so low, and could he benefit from trying an alternate medication that treats some of the MODIs, but he just didn't screen positive for those genes.
Can I start, Lisa, with some comments? So, yeah, this is a very interesting case, and thank you very much for bringing it to our office out here. This is exactly the kind of thing this session is designed for us to talk about, and we love to talk about these kind of cases. I think as you mentioned, a lot of the history does make you think about type 1. Even the mild DKA and the very high A1C at diagnosis and all that. And we know that, some percentage of type 1 is going to be antibody negative. And it is also possible that the last bit of beta cells that are left might take longer to be destroyed over time. And so that you could have a relatively low insulin requirements. So I would say type 1 diabetes is definitely still possible. However, the family history is very compelling here, particularly that dad, has some kind of hyperglycemia apparently that seems to, if the A1C of 7% is true, then meets the criteria for diabetes, but the fact that he is currently not on medical therapy, strongly suggests that he doesn't have type 1 diabetes. And so if we think there's a link between their diabetes, then, it makes it much less likely to be type 1. And then the paternal uncle, it's a sad story of whatever happened, but again, definitely speaks to the possibility of an autosomal dominant genetic cause here. What was I going to ask? I was going to ask if anyone else in the family has any autoimmune diseases like thyroid disease, anything like that.
I don't think so. I don't recall that being the case.
Yeah, and the IgA deficiency is a little interesting because
Yeah.
that is something that can go along with an autoimmune picture.
And then one other thing I forgot to mention too, I don't think this is relevant, but just throwing it out there is, and I think this goes along with IgA deficiency and his risk of autoimmunity. He did have a positive ANA that he doesn't have other symptoms of like rheumatoid conditions, but that's the only other positive antibody thing that's come up for him.
Yeah. And, it's worth kind of mentioning that there can be monogenic causes of autoimmune diabetes in addition to other things. And so again, the family history here is compelling enough that I would think we would want to pursue further to see if we can find something that either is something known that may not have been picked up by the Invitae panel. Most of these commercial labs run testing that's pretty good and fairly comprehensive, but there are a few gaps. And on our research panel, we test even more broadly for things that we don't necessarily know of. I mean, to say things that were kind of like candidate genes. And then even our radiant study, I think I'm curious what Dr. Phillipson would say, or Lisa, but I think this history would probably get through one of our adjudication committees on the radiant panel. At least I would hope, I would argue for them getting through. And there was one other thing I was going to say that I'm not remembering. So if Lou has something to add, I'm curious.
Yeah, it's a great case. I mean, I think, I've had friends from Ethiopia and Addis. I mean, the ethnicities in Ethiopia are very interesting. We often say that in some parts of the world, you meeting somebody randomly is at least your second cousin. Are both parents from Ethiopia and the same village?
That's a good question that I didn't ask.
Well, this is why we do this. We ask the tough questions here.
Yeah, I can ask when I see them again.
Yeah, so you could make a list of things to ask, but sometimes they say, well, yeah, we married my parents' cousin, and that's how it works in those days. So but there are many places where even first cousin marriages are not unusual, and that's interesting because of the obviously the possibility of recessive things with his family history. So I totally agree with Siri that absent the family history, we would say, gee, this is probably developing type 1, and we would just keep looking, and it's only a few years out that we would be sure. But given the family history, it's possible we could do a couple of things. So we would get more. I mean, and the ANA positivity is also interesting. I mean, was it just slightly positive? Was it hugely positive with a panel? That would be something else. You may not have that information now, but that would be something else to look at. Depending on how far out you get, it might be useful to get a C-peptide at some point with a blood sugar, if it's months or a year down the road. Although we lean to the Hattersley approach, which is don't bother with the C-peptide until like 3 years out, because it still could be high, especially if the honeymoon period is extended. But the advantage of doing what Siri suggested and enrolling in Radiant in that U54 study is that we would repeat the antibodies. So, and that would be for free. So we would get another set of antibodies, and because sometimes also on anybody, sometimes the second time is positive. We've seen quite a few cases in Radiant where the antibodies were either never done, and it didn't really look like, nobody was convinced it was type 1, or the initial set was negative and that the radiant set is positive. So that's something. And then we could obviously get whole genome and not just whole exome if it went through. I think at the same time, it's possible to enroll them in our registry, even though the negative in Vitae panel would be helpful to move things along in radiant, but our registry also, we could do a whole exome sequencing, but we also would do a T1 genetic risk score. Now, exactly how helpful that would be in someone with an Ethiopian heritage, is not totally clear, but the Richard Oram and has published with Maria Redondo and other people that the T1 risk score is actually not so bad in non-European populations. So those are some of the thoughts. I think it is an interesting case. I think there, it could be interesting, the ANA, it could be a clue, but there's certainly more to do here before we're sure. One thing I wouldn't do, though, at the end of the day, is I wouldn't start an oral agent just yet. But he for a couple different reasons, I would just go a little bit farther to try to make a diagnosis.
I thought of two other questions. The one that I was wondering about was if he's doing any kind of like extreme carb restriction, or not necessarily.
He's doing the opposite of carb restriction.
Oh, okay.
Yeah.
Then you would think he probably has a decent C-peptide production, but it would be good to document that. And I agree with Lou that in general, we shy away from non-insulin management in this kind of case where there's enough in the history to make you worry about type 1. The fact that he had the mild DKA and the very high A1C especially makes you worry for especially something like SGLT inhibitors, which have the risk of euglycemic DKA. And sulfonylureas, not being exactly the first line agent, not exactly what we could call healthy for the beta cells. You probably wouldn't want to go there. And then his BMI, the GLP-1s wouldn't be necessarily a great choice for that either. But here's one more question is, was he born in the United States? And do you know his birth weight and the birth weights of his dad and uncle?
No, I
Probably not.
don't know that. I suspect he was born in the US, but I don't know his birth weights or anything. I mean, he came from like 2 or 4 hours away. We didn't have a lot of records besides what was sort of an epic, but yeah, I think he was born in the US, but I don't know his birth weights.
So along the lines of really esoteric causes that wouldn't have been on the Invitae panel is like 6q24 related transient neonatal diabetes, and you'll be like, what the heck is he thinking? And there is at least one study in Japan where they took patients diagnosed in like adolescence, young adulthood, and were tested for MODY genes and everything else, and were not positive for anything, and found that a very small percentage of them had 6q24, but they were usually had relatively low birth weights also. And in this case, if you know anything about 6q24, you might think, is that really inherited? And most of the causes are not. But if you have a paternally inherited duplication, it could be inherited. And so in this case, the dad and the uncle would have had to have inherited the same duplication from their father. And so it's theoretically possible. I'd say pretty unlikely, but that's another thing that we could test for through the registry, in addition to either jumping to exome sequencing, or we might start with our research panel, which, for example, covers intronic regions of the insulin gene that aren't necessarily covered in the commercial panels. I guess Dr. Green is going to have to take off, but I hope that's somewhat helpful on
It
some
is.
ways we might proceed.
Yeah. No, it's very helpful, one, to just know that this may or may not be type 1 and may be atypical based on the family history, and then also just providing reassurance that I shouldn't be starting or trying some other medication besides insulin at this time. But hopefully I can loop back in with you guys about how to maybe get him referred to the Radiant trial or to the registry to do more testing.
Yeah, and I would caution against giving the family too much like of an idea of what might change as far as therapies and long-term outcome, but at the same time, really encouraging them to hopefully participate and provide samples so that we can get to the bottom of what's happening with the diabetes in their family. And if dad is able to provide a sample also, that would be that makes it so much more helpful in discovering a cause, especially if it's going to be a novel cause. So hopefully he will. And in fact, we'd want the mom and the dad so that we can do kind of filtering. So I hope that might be a possibility.
I suspect it would be. I think they were very interested in trying to help this child.
That would be great.
All right. Well, thank you so much.
Thank you, Dr. Green. Thanks for being
Thank
here.
you. Thank you for bringing the case. It was awesome.
All right, so we will move on then to case number 2. This is a case that we are submitting from our own registry. I don't have any relevant disclosures to share today. So a little bit of background on this case. This is a 36-year-old female. She was diagnosed when she was 10, had kind of classic diabetes symptoms, tired, weak, polyuria, polydipsia, some pretty significant abdominal pain. And they found glucose in her urine. Her blood sugar at diagnosis was 243. She was average weight. She's only ever had GAD antibodies checked, but they were negative. In terms of her medication history, she was initially started on insulin at her diagnosis at age 10, was on that for 2 years. And then from age 12 to 13, she was off of all medication and doing okay. And then at around age 13, blood sugar started to rise again. So she, I believe in her survey, she said she begged her doctor not to put her back on insulin. And so they started her on metformin, which worked, I think, surprisingly well from her perspective for about 10 years. She was then on and off several different medications, including glimepiride, long-acting insulin, canagliflozin. Notably, she did have significant hypoglycemia with glimepiride. Most recently, her A1C has been 7%. She was at that time using long-acting insulin, metformin, and a GLP-1 receptor agonist, but it wasn't working as well as they had hoped. She did have a couple other medical problems, preeclampsia with her pregnancies, ADD, anxiety, recurrent UTIs, and a high LDL cholesterol. Her family history was very significant for diabetes, especially on the paternal side. So I've listed just some of her family history here. You can see she has a father, a brother, paternal aunt, both paternal grandparents, and 2 children that are listed here. The people that are in red text had been tested and were positive for the same genetic variant that she carries, which is a variant in HNF1 alpha. So this variant was initially classified as a VUS, and after significant testing of her family members, as you can see here, and corresponding with our colleagues across the world about this particular variant, it has recently been upgraded to likely pathogenic. So I'm going to turn it over to Dr. Phillipson and Dr. Greeley, mostly for the next few slides. We just wanted to kind of talk through with the group some management considerations in HNF1 alpha MODY, including the things listed on the screen here, but certainly not limited to this. So if anyone has questions or comments about HNF1 alpha in particular, feel free to put them in the chat and we'll make sure we get to those questions.
Before Siri and I jump in, we have some wonderful guests with us today. I mean, so if people want to ask questions or contribute their own experience, we can just either put it in the chat or we just pause for a second here. But otherwise, we can go ahead. I mean, this is a rich case, and not unlike many others where we're uncertain of some of the aspects of what to do. I mean, Siri, would you like to comment unless anyone else wants to jump in here?
I'll let you start this time, and I will be happy to jump in at the end afterwards.
Well, I think what's very exciting for us is to always think about the whole family and who has what, and then how to think about whether any given mutation is actually pathogenic or not. We have now a considerable number of people who have come to us who we've helped move from insulin to sulfonylureas. And the question always is which one, how many times a day, are we seeing lots of hypoglycemia, and what to do next. So this is some of the data in the literature that it seems like a large percentage can be switched. I think we're seeing as time goes by, we see a considerable number of people who actually maybe don't work, and we haven't worked out the numbers just yet about how many that is, but there's both people who, the 30% who don't respond in the beginning, which we don't understand why, and then there's the folks who don't continue to respond. So after a while, we do need to switch. But in many cases, the A1Cs are better, compliance is higher, at least in those initial times. And then what we wrestle with are all those things. How long have they been on insulin? So there can be a gradual time of increasing the sulfonylurea dose while slowly decreasing the insulin dose to be sure the insulin cells are woken up. There is this notion that significant amounts of insulin can cause the insulin secreting cells to reduce gene expression, and so they may not function immediately, so that we have to avoid disappointment and start slowly. A lot depends on whether there's other features. One of the things we're looking at right now is whether genome-wide association studies can help us understand the impact of type 2 diabetes risk scores, but even simple clinical measures, so waist circumference, family history of obesity, other features of metabolic syndrome, high blood pressure, and so on, may have a big impact on whether sulfonylureas will increase insulin secretion sufficiently. And this is where then continuous glucose monitors can be incredibly helpful. I have had patients, depending on their insurance, where the insurance pushes back. Unless someone's on insulin, they may not be able to get a continuous glucose monitor. So sometimes we prescribe insulin and tell them not to use it, just so we can be sure their continuous glucose monitors are covered during this period, and especially if they're getting hypoglycemia. We want to correlate the actual hypoglycemia with symptoms. And this is where the glitinides may be helpful. So some of the older ones, we're talking about the old guys of Prandon and Starlix with the brand names, and repaglinide is one of the ones that has a quicker on cycle and a quicker off cycle. So originally designed as a mealtime insulin, mostly used as a way to look at genetic impacts on drug disposal over the last few years, and not so much for diabetes, but they are still available. And we've had some luck in giving those drugs as mealtime doses, and then using glyburide maybe at night or glimepiride at night to have a long-acting, more moderate sulfonylurea. The problem becomes exercise or missed meals. And while it's interesting, we've done some modeling studies some years ago, just mathematical studies on the combination of glucose and sulfonylureas or GLP-1 and sulfonylureas. And so there is a mealtime effect. You don't get sulfonylureas to work all the time, but they seem to specifically induce insulin secretion when the blood sugars are higher. So you have at least some benefit there, but still the possibility, when you combine that with exercise, of low blood sugar and low blood sugar at night. So having CGM, at least at intervals, seems to be very, very useful. I think serious experience, and maybe you can speak to this in the really little ones, so the neonatal hypoglycemia with sulfonylureas, is that the dosing there is much higher, and we have people interested in that, and sometimes it's 2 milligrams per kilo per day or higher, but those are different. Those are the KCNJ11 mutations and not the HNF1 alpha mutations, which can actually be very sensitive. It's not listed here, but one of the hallmarks of HNF1 alpha and sulfonylureas would be hypoglycemia with teeny tiny doses. So we often start people with a half of the lowest dose, so 0.625 milligrams for one. And some of these folks will tell you, my doctor tried sulfonylureas, it didn't work. Why didn't it work? Because I went low right away. And so that can be a clue that sensitivity to sulfonylureas suggests a 1 alpha mutation, occasionally a 4 alpha mutation, MODY1, but more often it would be MODY3. So that's some of my reactions to this slide and what to do. And I think there's more, right? So the next slide. So one of the things that keeps coming up is whether we need to screen families for hepatic adenomas. So the liver cancer people are quite familiar with HNF1 alpha because somatic mutations are frequently seen in hepatocellular carcinoma. So as part of the multi-hit process to go from adenomas to carcinoma are HNF1 alpha mutations, but it seems to be an entirely separate literature. And the people with genomic mutations, who are typically MODY3 HNF1 alpha folks that we see, rarely get adenomas. So I don't think we understand what tips someone over into getting adenomas. I don't think there's ever been a screen in very large numbers of folks as to whether there are very small adenomas. You would have to do CT scans, I think. I don't think ultrasounds would be sufficient. We have several of those people out of the 300 or 400 or so HNF1 alpha folks in our registry. Just a handful have had adenomas, and just a subset of that have needed surgery. And so the question is, do you screen? And I don't know that there's really consensus about that. It seems to be rare enough that if there's some adventitious reason, a car accident or some other reason, or sometimes the adenomas are compressing the biliary tree, so there's a little bit increase in bilirubin. I don't know that we have a consensus on screening in all cases, but certainly in adults, it's something to think about, and it has been recommended. I don't think we have enough cases to say that this needs to be written in stone, but I think it needs to be thought about. Even in that one cohort, which I think that's a Philippe Fragel cohort, but now I don't remember the senior author. But that was 6%. Do you want to get CT scans in everyone, or just be aware of the possibility? So I don't know how you feel about that, Siri, if we should be screening people.
Yeah, I was wondering about this too, as we were thinking about this case, that I don't think all of the groups, I don't think there has been a consensus that screening is recommended for all families. I think it's mostly just in the context of this cohort in France, where they had made the recommendation with these publications. I guess the challenge is if they could have them asymptomatically, you would have to do screening to come up with it, but then what you do about it is not entirely clear either. So I think that actually does kind of argue a little bit against screening, but certainly remembering that it's a possibility, and if there's any kind of symptoms at all, particularly anything like jaundice or anything like that, or belly pain, I suppose, if somehow they were compressing something or that kind of thing, it should be considered. Lou, I was going to ask you this. It sounded like the original case there at one point was treated with an SGLT inhibitor. Did you want to mention about that?
Yeah, we talk about that a lot amongst ourselves here, and also influenced by Professor Hattersley, and also my friends Ann Peterson, John Buse, that we worry a lot since this is an insulin deficiency syndrome. The concern is that SGLT2 inhibitors could lead to euglycemic DKA or hypotension even. So that was, I think, Hattersley's concern, is that you might, since you already have, and I think the background here is that HNF1 alpha is a transcription factor for SGLT2. So people who have HNF1 alpha insufficient already have a decrease in SGLT2 expression. That probably explains the glucoseuria, which often leads to the diagnosis. So a kid pees in a cup for a sports physical, and there's sugar there because of the decrease in SGLT2, even when the A1C and the blood sugars are normal, but there's a decreased threshold then for the appearance of glucose in the urine. So then you add the SGLT2, and on the one hand, you have a concern that now you have a dramatic reduction in SGLT2, so you lose both water and glucose into the urine, and you could have hypotension, at least theoretically. I don't know that that's been reported. We keep looking for that. Clearly, people who aren't SGLT2s do have some volume reduction before things equilibrate in adults. But then on the other side of the coin is reducing the insulin requirements. And we're trying to be sure that people realize that this isn't type 2 diabetes. It is more like, it is in fact an insulin deficiency syndrome, and that it's possible SGLT2s really ought to be contraindicated here. GLP-1 agonists, on the other hand, ought not to be lumped, and in some cases, they can restore sulfonylurea responsiveness. So it looks like increasing, and that could be an effect on the pancreas. We're all now alerted to the GLP-1 effects in the brain, which probably is where most of the action is, but they still work on the pancreas, and the idea that a little bit of extra cyclic A in the insulin secreting cells, among others, could enhance sulfonylurea responsiveness. So in some cases we've done that, and then very cautiously, because most of these folks are not overweight.
Yeah, no, those are all great points, and I would just want to emphasize that I think the GLP-1s would be especially helpful when the sulfonylurea isn't enough and their A1C is going over 7, or later in age. I've heard people tend to gain more weight, you know. In fact, yeah, personal experience. I mean, I think that may be part of what is driving the in like the historical papers, the fact that sulfonylureas aren't necessarily sustained forever. And so people may be building up either from overweight or just maybe physiological insulin resistance or whatnot. But a second agent added at that point, such as GLP-1s, would be, I think, a really good choice, because one thing that we have learned as a group, very much so over the past year or so with our precision medicine initiative we've been involved with, was scouring the literature for the risk of long-term diabetes complications and several forms of MODY. And what is very clear from even the very limited literature is that unfortunately people with HNF1 alpha mutations or 4 alpha mutations in particular are very much at risk for retinopathy, nephropathy, neuropathy, and as well as higher cardiovascular risk. And so that's kind of one of the disappointing things about not being able to use the SGLTs possibly, but the GLP-1s also have a really similar benefit of risk reduction. So I think I feel this may be one of the kind of newer conceptions as we go along in the next decade or so, is thinking about those other agents to add on instead of necessarily just reverting back to insulin therapy.
The role of metformin is interesting too. I mean, I often counsel against metformin in this situation, and yet time and time again we see folks who at least had some temporary benefit. And so if there's an element of insulin resistance, especially, metformin can help reduce blood sugars at least for a while. So I'm always surprised when it works.
And you mentioned the neonatal cases, and I would say there's an analogous situation where in those instances, as you mentioned, we go to these high doses of sulfonylureas, but oftentimes that isn't enough, particularly as they get much older after they go through puberty. And so the additional agents that have been helpful have very much been even metformin, as well as the GLP-1s. And so I think it's great to still have other options besides just insulin.
Yeah,
I think there's one more.
Yeah, there's 2 more slides. You mentioned
2 more.
cardiovascular disease risk, though. So maybe Dr. Lee, do you want to start with thoughts on this?
So I don't know. So either Siri or me, but yeah. So there are several studies going way back. I mean, there's even earlier studies looking at subtle variations in lipoprotein subtypes in HNF1 alpha. So we remind ourselves that HNF1 alpha is was hepatic nuclear factor. And so while it is important in the insulin secreting cells, probably more important for some transcription, including the insulin gene, it's also critical in the liver. So, and we mentioned the effect on SGLT2. There's also effects on apolipoproteins and cholesterol. And so there are interesting subtle variations. So in at least this report, HDL cholesterol was higher, but there are other subtypes that might be higher in some reports. I don't know that we have a definitive study. There was, I think, a mouse study very early on with Marcus Stoffel, probably in the early 2000s or late 1990s, where it wasn't completely clear what the response should be. But it does look like over time, people with HNF1 alpha who are not well treated will develop cardiovascular disease, just as if they had type 2 diabetes. And it seems very reasonable to start a statin early on. So that's something that we do look at, even if and it's been recommended by the Hattersley group to start a statin, even if the HDL LDL ratio is not so abnormal. So that is something that we've been doing ourselves.
Yeah, and our last plan slide, but of course, if there are questions, again, feel free to put them in the chat. Our last plan slide was to talk about the variable age of onset in HNF1 alpha and also when to test children of affected family members. And I wanted to just go back to our case here for a second. So this particular participant was very motivated to test her children, to do genetic testing on her children. And you can see there that she has one child who's 8, who doesn't have an official blood sugar diagnosis, but is experiencing increased bedwetting and thirst. And that child does carry the HNF1 alpha variant. Her other child, who is only 4 years old, was negative for the variant and also doesn't seem to be having any blood sugar issues. So definitely we see differences across parents. Some parents are really eager to test their children, some are not. So I'll pass it back to Dr. Phillipson and Dr. Greeley.
Question is what to do. I mean, if there was a parallel to type 1 diabetes, we certainly try to get antibody testing early on. And the literature in TrialNet is crystal clear that if you know ahead of time there's a soft landing, there's less anxiety, and testing and doing all the things that we might do for HNF1 alpha in terms of diet, exercise, which can work in 1 alpha, as opposed to, say, glucokinase mutations, that all of those things can be put together earlier on. So, and especially then avoiding sort of the inadvertent reveal with a sports physical or something in middle school. And it is interesting that the variability is so high. I mean, one of the things that we're trying to do with our new data commons that we're launching is that, and with Michael, who's listening, Michael is helping lead that, is to understand how we can get enough folks to see whether there are ways of understanding the variable onset of the disease. So we know that the great majority of people will have diabetes before the age of 25. In fact, that was the original definition by Dr. Fyans and his colleagues for MODY in general. But not everyone will. We certainly had people in their 40s to have the first impact of diabetes and HNF1 alpha, and we've had kids, 7 years old or so, or even 6, I think, in one or two cases, also clearly have diabetes. But even in one family, there's a lot of variation. Some families not, some families, yes, you can have kids, you can have adults, and I don't know that we have an answer to that either. So one of the reasons to have a combination of registries where people are tracked over time is to help answer this question. In some of the registries, it's a one-off. They only come to attention for genetic screening, and there's no follow-up. So we can't know in the rest of the family, based on that data, what happens to people. In our registry, we are able to track year by year, and we can then see prospectively what happens. Of course, we can go back and take family histories and see who did what when. And possibly look at other factors, as there are other genes, whether there's an effective imprinting in some way. And what we haven't found is whether there's any particular impact of specific mutations in HNF1 alpha, except in a general way about where in the in the protein, but the detailed mutation isn't there. There's some evidence, I think, early on that depending on whether the mutation was in the DNA binding region or the protein interaction region, that can affect age of onset and to some extent penetrance. I still think we need to learn more about that.
Yeah, I would only add that I think a big part of what is likely happening is that there's a variable amount of, dysglycemia or whatever you might want to call that could be happening even for years before the actual diagnosis. And so a lot of it, I think, just depends on ascertainment and how people are being tested, or how often, and are they getting, an A1C, are they getting continuous glucose monitoring? Probably mostly aren't. And so it's definitely something of interest to be looking at, because one concerning part of that is if people are going many years with some degree of hyperglycemia and just don't know it, that could be contributing to future risk. And so we definitely want to improve that. One last point I would want to emphasize about the genetic testing and seeing in this family just how many people we were able to test through the registry, is that makes a big difference, not just for this family where it makes an obvious difference, but the fact that it was literally that doing that for this one family what allowed us to gain enough information about the specific variant to change it from a variant of uncertain significance into a likely pathogenic variant. And that means that anytime anyone with that variant in any lab across the world has that variant pop up, now we understand better the significance of it, whereas before we wouldn't have. And so my point here is anyone, not just on this call, but who might be listening to this later, is if you have families with MODY in your practice, or any kind of monogenic diabetes, and even if they're doing wonderfully well, and you have them on the right treatment and you're doing great, we would really, 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 really encourage you to please try to get them to join the registry, so that we can, gather the data that then contributes to what is known, and really does that aggregate data, really does make a difference in the long run. We also, by the way, do try to provide all kinds of support to the families. Both we can offer like family member testing, we have webinars and things like that. We even previously had done some family meetings, and we offer, if people want to participate in different studies, they can do that through the registry. So there's lots of reasons to refer people to join. It's really easy for providers, because all you have to do really is just point them to our website. They sign up, we give them a call, we do the consent, we take care of everything, and you really don't have to do much. So I appreciate everyone who is listening and hopefully getting something out of these sessions.